my title, as you can all see, is The Journey, 4 Cusps, Walking, Chant and Pilgrimage. Now, the 4 Cusps aspect is very medical and is all about doctor-patient communication for patients with cancer. And remembering that I'm a gynaecological surgeon, all of my patients are women. So I tend to always just talk about women, but much of this stuff is relevant clearly for men in the same position. We will then move on to out of the medical arena through some psychology and then get into stuff around spirituality and chant, lead that on to cardiac coherence, which is a secular form of chant, and finally finish with some stuff around pilgrimage. So it's quite a wide-ranging talk. And just to start, I hope this sort of generates the right sort of feelings. I'm looking out of my window here in central London and the sun is setting. This is the sun setting over Loch Fyne. The Creggan's Inn, a fine hostelry, which was the Fitzroy MacLean place, he who James Bond was based upon. This is the view from that hotel looking down Loch Fyne side. This is north of Bute and south of Iona, because these 2 islands come in later. So here's a quote for you folks. Surgery is the best of medical sciences, less liable than any other to the fallacy of conjectural or inferential practice, pure in itself and perpetual in its applicability. Now, it's obvious that a surgeon's put that sort of slide up, isn't it? Could be any feedback from the audience as to when you think that might have been written? I know you've got to unmute yourselves to do that. It's not got quite the immediacy if we're in a lecture theatre. No, we're not.
1920, 1920.
Okay, let me give you the next bit. The worthy produce of heaven and the certain source of fame.
I was going to say 1860.
Right, we're going back. Look, it was actually 600 BC. Ah. It was an Indian surgeon, Damantari. Okay. Now, what has that got to do with this talk? Actually, nothing really very much at all. Just sort of gauging whether we're all here or not. What we're going to start with is the topic of breaking bad news. Now, this is a subject which terrifies all new doctors, and it can always go wrong. But there are some, there's a lot of golden rules to my mind around this subject. And these are obvious things to start with. So there's the setting, right? And I'm a hospital doctor. We have to be crystal clear that if you're in a hospital and you're on a ward, particularly an old-fashioned ward where there's more than one person in a room, then those curtains do not allow for privacy, and a separate area should be used. And I have to say, I'm very pleased that the places I work, we've got that. The time allocated, this has got to be 30 minutes plus, and often much longer. Who is present? Well, this is become a very vexatious issue, because we would always, up until a year ago, have said the patient and their supporter, their nearest and dearest, whoever they've brought with them. But as you all know, in the era of COVID, I'm sorry to say, and I was on the receiving end of this, you go into hospital alone and you have no supporters, unless you're on a Zoom, in which case you might, but this is not an ideal thing to do over a Zoom at all. And then there's the vexed question of how do you start the conversation? Now, I know when I was a medical student that there was a lot of stuff about kind of asking the patient what they thought might be wrong with them and all that kind of thing. I have to say I'm not really a believer in that. I think that a relatively blunt approach is better, because most people have already guessed what the score is. And that, though, brings in what I would say are first set of golden rules. And first one is never say never. And what I mean by that is that we have no clue what any one of our patients' pathways is going to be at the start of the embarkation. So we have people with what look to be a dreadful prognosis who do remarkably well, and we have people with a wonderful prognosis who do terribly badly. The second and the third things, to me, are the total essence of this, which is that, firstly, always tell the truth. And if you always tell the truth and you never tell lies, and my own experience from being a young doctor. I did once lie to a patient. I lied at the point where he asked me how long he'd got, and he was a young man, not much older than me, and he had a malignant mesothelioma. And I couldn't bear to tell him that his statistics were awful. And I told a lie. And in fact, he said to the sister, I was a young houseman, and he said to the sister afterwards, he said, that guy Smith's all right. And he told me the truth right to the point where I asked how long I got, and then he lied to me. So people usually know if you tell lies, very bad idea altogether. If you tell the truth and don't tell lies, it's really easy to tell the same message to everybody. It's terribly important to take the team with you, particularly when looking after people who are very sick. The team have to believe in the route of travel that's been decided upon. And we then come to prognostication, and that is a vexatious subject to say the least, and great care required. Next set of golden rules. It's never true there's nothing more that we can do. And I'm going to come back to that much later in the talk, but I always think of the medical oncologist who taught me as a medical student was Professor Kenneth Kalman, who of course became very famous because he became the Chief Medical Officer of England, and he wrote the Kalman-Hein report, which radically changed for the better oncological services within the UK. But there was a very famous story, and it was at the time I was a medical student, about 1980, in Glasgow. And Ken Kalman had asked a woman on the ward if there was anything that she thought that if she could wave a magic wand might happen for her. And she gave the very simple reply that she'd like to have her hair done. She was terminally ill and in a bad way. And he, in fact, he arranged that for her. And that to me is axiomatic of an empathetic approach. So we should always give a treatment timetable. We should back it up with written information and pictures. We should finish on an up note. And remarkably, at first meeting with virtually all patients, it is possible to finish on an up note. We need to repeat the vital bits of the message ad nauseam, dare I say it. There's no harm repetition. And we need to use the cancer word. I know that many years ago, people talked about, tumors and mitotic bodies and all this stuff. Patients understand the cancer word. We all understand the cancer word, and it's all out there, and we know what we're talking about. So I'm now going to bring in this 4 cusp approach, and this was developed by myself, Mark Bauer, medical oncologist at Chelsea Westminster, Catherine Gillespie, who's a specialist nurse. And we actually had it assessed by a psychology PhD student, and I'm going to just allude to that stuff in a little minute as to which aspects of what is in essence a pictorial model seem to resonate with patients. And that was Gulshan's PhD. This 4 cusp approach allows active involvement of patient in their own management. It's a map for all cancer patients. It is not a clinical model, and it's really important to say that I know many of the audience are medical. You all know, we all know that cancers are staged depending on how far advanced they are. So stage 1 is localized, stage 4 furthest advanced within the FRCOG staging system, which is what we use in gynecology. This 4 cusp approach has no bearing and no association with FRCOG stages 1 to 4. It's really important to say that. So our cusps are A, B, C, D, but there is no relationship. And it's based on 3 important factors. It's physical, psychological, and it ties in with life expectancy and quality of life. And we developed it originally as a method of trying to truthfully answer the unanswerable question, how long have I got, doctor? And that is an unanswerable question always, to my mind. Well, not quite always, but most of the time. So here's these 4 cusps. There's cured, and I should say that I've got to use my my little arrow. The cured should be in inverted commas here. And there's living with cancer, which should also be in inverted commas. And I'm going to explain this in great detail in a minute. We've then got pre-terminal, cusp C, and cusp D terminal. And I have drawn down here a big dotted line. Now, just to show you this, because this comes like this, given to patients. It's a drawing done in clinic, A, B, C, and D. Now, when we've drawn this, most patients presume at the moment they walk in the clinic that they're in cusp C, maybe D. But I can tell you, I'm in 30 plus years of doing this, more actually, 35. I've only ever seen one patient who presented over at cusp D, actually at presentation, right? So most people are over here. And the Gulson model, what was shown was we always fold this piece of paper. And what's fascinating is that when patients return to clinic, they will often produce this piece of paper. It's done slightly smaller in clinic, because this is for the talk. But they've got it in their handbags, they've got it in their purses, and it's always folded, right? So it's really, it's part of what resonates. So here we go. We've got cured in inverted commas. Now, why is the cured in inverted commas? Because quite clearly, after you've treated somebody, you cannot possibly tell somebody that they're cured until 5 years has elapsed. We're terribly fortunate in gynaecological cancers that actually, if a patient has been in remission and remains in remission for 5 years, her chance of getting a recurrence of the tumor which she had is less than that of her developing another completely different cancer. I'm all too aware that this model does not work for certain cancers. There's certain types of breast cancer which unfortunately can recur many, many years later. The living with cancer, and you will realize as this explanation goes on, that it's a slightly semantic division, but it's to do with what the patient is thinking and feeling. And then there's pre-terminal and dying. So cured in inverted commas. So the status, the patient clearly to be put into cusp A has to be potentially curable. Now, the majority of patients who walk through the door fall into that category. The reason why I have put, I've lost my arrow, the reason why I've put duration weeks to years is because clearly post initial surgery or diagnostic tests, people may move cusps. The treatment is usually radical surgery, but there may be adjuvant therapy. And the aim is cure. It's also prolongation of survival. Now, if you don't mind to look at the screen again, where I'm sitting here, these cusps are 5 years long, right? But the idea is that when you get 1 year, 2 year, 3 year, 4 year, 5 year in remission, you then get in the cured circle, the inverted commas, excuse me, disappear, and you genuinely are out the other side of this. That's the goal, right? And Gulson's thesis showed that this circular aspect played very heavily with the patient in a positive way. So to give you just some case examples, right? We've got a young woman who's got a cervical cancer, which is small, and she goes forward to have a radical hysterectomy. The radical hysterectomy is performed, we get the histopathology back, and it involves removal of the uterus and the lymph nodes. She has negative lymph nodes, complete resection of the tumor. She is in cusp A. She's on a 5-year journey of follow-ups, and at the end of 5 years, if she continues in remission, she is almost certainly cured. An odd exception, I won't dispute, but very, very rare. Scenario 2, the patient has positive lymph nodes. Well, she's now going down a route of chemoradiotherapy. Excuse me. And so that patient is now bounced into cusp B. But cusp B is 5 years as well. But this, and of course, the goal is at the end of 5 years, she gets in the cured circle. Now, to give you another case scenario, we've got a woman with ovarian cancer, which is presumed to be a stage 1A. So that's a tumor which is confined within the ovary. That's what the scans all say. So she has her laparotomy, and that's confirmed. So she's got a stage 1A ovarian cancer. She's in cusp A, and she will be monitored for the next 5 years and hopefully will remain in remission, at which point she can be regarded as cured. Scenario 2 is that unfortunately at the laparotomy, there are small studs of tumour on the diaphragm that were not picked up on any of the imaging that was done beforehand. So she ends up with a more aggressive operation, but she is also about to go down the route of aggressive chemotherapy. And that woman is therefore in cusp B, which is living with the cancer. Now, I want to point out something, the difference between A and B, which is that from the patient's point of view, and I suppose I'm biased because I'm a surgeon, there's a definite elegance if you've got a cancer and somebody cuts it out and it's in a pot in the laboratory being looked at by a pathologist, rather than having chemotherapy or radiotherapy where one has to imagine that the tumour is melting away. And I have to say, it's always amazed me as a surgeon when you see people who are post-chemo, the enormously dramatic effects of chemotherapy. So it doesn't surprise me. It's difficult for patients to visualize this stuff. So the woman who's living with cancer, the duration of this is clearly months to years. This is patients who are either had surgery followed by chemo or radiotherapy, or they may be patients who are having upfront radio and chemotherapy. They've clearly got lesser chances of cure because the people in cusp A are all sitting way over 90% chances. These are people who probably within our arena are sitting at somewhere, the kind of 25 to 80% long-term remission rates. Our aim, and this comes back to this, our aim is to try to get people over to the cured circle after the 5 years, but we're certainly all about prolongation of survival and improvement of quality of life. So that's just the cusps on the screen there. And remember, the page is folded and we've got the patient here and we're going along 1 year, 2 year, 3 year, 4 year, around to 5. And at 5, they get over here into the cured circle. So scenario 1 is our ovarian cancer patient, and she has been treated with chemotherapy, and 5 years later, she's still in complete remission. Well, she's out the other side. She's lucky. She's very lucky. She's in that cured circle. Scenario 2 is that people relapse after 2-3 years. Now, clearly that's not good, but actually those people go back to the beginning of cusp B because they're back on the route of surgery, more chemotherapy, and they're likely to get something similar the next time round. Now, I know my record patient who remained in the living with circle, she was in the living with circle for 17 years, in fact, with operations every 3 to 4 years and chemotherapy. So, it's highly variable depending upon the cancer. Scenario 3 is the disaster where somebody relapses at under 6 months because those people are not likely to do well with further chemotherapy or surgery. And this is where, and I'm going to just go back to this. This is the final upside of this very simple model, is that to me, possibly the hardest conversation you ever have is the person going from B to C. And I have to say that there's many times that patients have actually pulled out the piece of paper and they've said, I think I'm arriving in cusp C. And all one can do is to agree. And it's made that hardest of conversations marginally easier. So cusp C is pre-terminal. And this is the view, I think, that many of the public have of cancer. And that's not a surprising image to have in people's minds. This can last from weeks to months. And it's important now to be quite clear that treatment is supportive and it's about improving quality of life issues. Oh, somebody's unmuted. To me, the real essence here is the golden rule question, which is to ask the patient what they feel is wrong and for us not to presume to know the patient's real problems. And also it's time to put one's house in order. And so the vital question is to sit and talk to people about what it is that is getting to them. And my favorite question has been, we know we can't make you live longer. If we could wave a magic wand, is there anything that you would want us to try and make happen for you? And the asking of that question certainly produces some responses that one could never ever have anticipated. So I know we had a patient in Annie's Aunt's ward at Chelsea and Westminster, and she was close to passing, not far away really. But there was something going on for her, and I sat with her very quietly, and she suddenly just said, I've got papers in my loft at home and they have to be burnt. I don't want my family to see them. And I said, I'm going to talk to sister, because I don't think I can help you personally here, but I think sister probably can. And Sister Giselle Leonoy, long retired, wonderful lady, and she organised an ambulance and put a staff nurse in that ambulance with the patient, and the patient went home. And the stuff was got from the loft and burnt, and she came back into hospital. And she, in fact, passed away within 48 hours. And that's kind of, it's the sitting and the talking. So, Cusp C, I'm going to give you a clinical scenario. We have a woman, and these are all real scenarios, right? This patient in particular sticks so strongly in my mind. So she was treated for a stage 3B cervical cancer. Now that's a cancer which has spread way out of the cervix and through to the pelvic sidewall, and she's been treated with full dose radiotherapy and chemotherapy. And sadly, she's relapsed 3 years later. She's got enlarged para-aortic lymph nodes, and she's got a large cystovaginal fistula. So she's got no control over her urine, which is passing freely from the bladder into the vagina. And there's active tumor involvement at that place. So there's nothing that can be done for her surgically, and there's nothing that can be done for her with respect to radiotherapy or chemotherapy. And I met this poor woman on my ward round, and it was a Tuesday afternoon, about 5 o'clock. And she was in the side room of the ward, and I walked in, and she was so angry. It was an astonishing sort of first meeting. And I asked her why she was angry, and she said, I've been told there's nothing can be done for me. Okay. So I said, that's not something I've said to you. I said, what? I said, I know you're really angry. And I said, I know it's probably really obvious what you're angry about. Maybe I think it's obvious, maybe you think it's obvious, but I actually don't know quite what you're angry about. So there was a bit more kind of like bad stuff going on. And then she just shouted at me, she said, it's bloody obvious. And I said, okay. I said, it's not actually obvious to me. Tell me, please. And she said, I stink of piss. I went, oh my God, that wasn't what I was thinking at all, right? So I said, look, I said, okay. I said, I don't have a trick, but there's a clever guy downstairs in interventional radiology. He does have a trick. I said, we're going to get 2 nephrostomies into you, onto a urine bag on your leg, and we won't make you 100% dry, but we'll take you a long way down that line. And that's what happened. The interventional radiologist intervened. She went home. She spent the next 2 to 3 weeks going out. She had dinner with her friends. She was going to restaurants. She had a very good time. And then she came back in and she passed away in 48 hours. And she made a generous contribution, I have to say, to the Ward Christmas Fund. The whole thing comes back to actually finding out what it is that the patient's worried about, not what we think they're worried about. And I know as a surgeon, we're always kind of obsessed with trying to get people to be cured and what can we do about this and do about that. And sometimes that's not actually, it's not the deal at all. Now, Cusp D dying is outside the scope of this talk. This is terminal care, improvement of quality of death and end of life issues, and we're not going to touch on that. Now, I now want to move to the psychological aspects of the cancer diagnosis and treatment. And DABDA, many of you will know, have heard of, may well have read Elizabeth Kubler-Ross, the American palliative care physician's book, which was published in the 1950s. And in this, she codified a grief response. And she codified it into this bit here at the bottom: denial, anger, bewilderment, bargaining. Have these people given me the right result? Have they mixed up the histopathology? Who's stuffed up what? Depression. And then there's acceptance, hope. Now, one of the issues for things that went slightly wrong with the Kubler-Ross model was that it was taken up by a lot of counsellors who saw it as a linear process, and Kubler-Ross never did. She saw it as random. And I prefer this model. Now, the Reverend Gary Bradley, who's the Vicar of Little Venice, also the founder of the Westminster Bereavement Association, is one of my very dear friends, and he and I quite often lecture together. And this model is his model, the landscape of grief. And I'm sure most of you have got, maybe not all of you, some people are very reductionist these days. They don't have any pictures on the walls at all, but most people do. And I can see Emma's background. She's got some pictures in the background. You can see from my background, I've got some pictures, right? Well, when I bought those pictures, there was something that drew me to them. And over the next few weeks, as I walked past the pictures, there might be something which came out of more that came out of the picture. If the picture's any use, there is. But there is a point where the picture becomes wallpaper. And that is when one reaches acceptance, hope, so that this terrible event begins to fade into the past. Now, to me, what's also fascinating is that most people think that the denial, anger, bewilderment, depression all happens actually quite early on in the cancer process. To my experience, it doesn't at all. What tends to happen is that the patient is very focused through her surgery and surgical recovery, and if she needs chemoradiotherapy, through that process as well. And it's usually at the 6-week point post-surgery, if there's no adjunctive treatment, or at the point post-chemoradiotherapy where all the treatment's finished, and we say to the patient, pat on the back, oh, it's all cool now, everything's great, right? And our family are going, oh, you're in remission, no, everything's looking great. And the patient goes, what? I have just been put through hell, and suddenly this little lot starts appearing. Anger, bewilderment, depression, it's all over the place. And this is the time where we need some new interventions without just patting people on the back and going, hey, it's top job, we'll see you in 3 months, right? Because it doesn't tend to be. So I now want to just bring in an observation, which is that there's an element of a bimodal distribution in how patients respond to their cancer diagnosis. From the cup half fulls, who see their cancer diagnosis, ironically further down the line, as actually rather a positive thing, because it's made them value each day they've got, each month they've got, to the cup half empties, who sadly get into terrible fear of recurrence and waste all the time that they've got, right? So what alternatives have we got to help people? Well, nutrition. Now, clearly good nutrition is a good thing, but there's much more to this than, and I'm not talking wacky diets here, it's the whole control aspect for the woman to get control over something where, in fact, things have been right out of control. Her body's not been doing what she wanted to do at all. Acupuncture can be helpful. Hypnotherapy can be helpful. And Sean Hammond, my great friend and long-term, we've worked together for 25 years. I used to run a hypnosis clinic. Sean and I have worked together. When I became a consultant, I hypnotized two of my children, occasionally the odd patient. There's counseling. There's chant, repetitive chant. And we're going to talk a lot more about that in a wee minute. And then there's psychology, spirituality, and religion. Now, you all know that I'm a gynaecological surgeon. I'm allowed to talk about psychology, but I'm not really meant to talk about spirituality at all. And religion, keep clear, is the overriding message, right? But I can't actually date it. It's probably 15 years ago, maybe more. Was invited by the Charing Cross Cancer Patients Association to deliver a talk on doctor-patient communication for patients with cancer, right? Now, this is a real Daniel walking into the lion's den job, because I walked in a room at Charing Cross Hospital at 7 o'clock on a Wednesday evening or whatever evening it was, and there are 55 people in the room, all of whom have had cancer, some of whom have still got it, and some of them had been my patients. And it dates it, because I had a slide carousel, right? Now, that's a long time ago, isn't it? Slide carousels. So I've got my slide carousel, but as I walk in, I realize there is no slide projector. And in fact, there are no audiovisual props whatsoever, apart from a flip chart. Now, the talk I gave them was the talk you have heard until this point, right? It's that talk. And I then said to them, I'm going to now discuss this little bit: psychology, spirituality, and religion. And I said, I know that I'm not meant to talk about spirituality and religion. I hope I'm not going to cause any offense, but I would like to talk to you about it. Well, the room erupted. And there was one woman, she pointed at me, she says, you and your bloody nurses, you will not discuss this. This is what we want to talk about. So in fact, the response I got from this was a complete plumb opposite of what I thought I was going to get. And it's that response which, dare I say it, emboldened me to write about this stuff and to publish that book, The Journey, right? That's kind of where it all started. So it's a big thank you to the Charing Cross Cancer Patients Association. I showed them, and I drew on their flip chart, this Venn diagram. Now, this Venn diagram is something which I draw after I've drawn Dabda Landscape of Grief. This tends, and the four cusps is much earlier, this tends to get shoved across the table to patients. And you say, not pushing anything here, but does any of that resonate with you? Now, you get fascinating replies. People go, oh, yeah, but this resonates, that. Not so long ago, there was a lovely Irish woman who'd had very radical surgery in her late 20s, disastrous, really. And I, at the 6 week, she was in the cusp A, but at the 6 week point, I said to her, I pushed this across the table at her. And I said, what do you make of that? And she said, I've got a psychologist already. She said, my brother's a priest. She said, I'm right into my religion and spirituality. It's really that's right up my street. And she smiled, and you just kind of knew that she was kind of heading the right way with this stuff. So is it important? Well, it's difficult to measure. There's quite a bit of evidence for sure that taking any of these approaches or a mixture are likely to improve one's well-being, certainly in psychological terms. I would not make any claims for physical terms. And then, of course, the question is how. I think it's important I do just define spirituality before we go any further. And the definition I'm giving you there is the Oxford English Dictionary. One's experience or attempt to experience sense of the transcendental, either independent of religion or within the setting of a religious ceremony. I think if you go back up to this, one of the fascinating things is that there are few priests who will discuss psychology, and many are not particularly interested in talking about spirituality either, truth to tell. Psychologists certainly don't want to discuss religion or spirituality. And in fact, a lot of patients want to discuss spirituality at the end of the day. The one person who crossed that was the great Swiss psychologist, who I'm a huge fan of, Carl Gustav Jung. And many of you may have read Jung, The Meaning of Psychology for Modern Man, Man in Search of a Soul, Lawrence van der Post, Jung and the Story of Our Time, all good starting point books. And I mean, there's what I think is a wonderful quote from Jung, because Jung crossed all three of these areas, which was, and you know, he was into dream analysis. The dream, I'm just reading it, the dream is the small hidden door in the deepest and most intimate sanctum of the soul, which opens to primeval cosmic night that was soul long before there was conscious ego, and will be soul far beyond what a conscious ego could ever reach. That to me is quite a good insight into Jung's thinking. So I'm now going to move on to chant. And chant is repetitive prayer if it's done in a religious setting, but it can also be done in a secular setting via cardiac coherence or mindfulness. And all the world's big religions have sects who chant. So there's a lot of Orthodox Christians doing the Jesus prayer, and this is having a mantra, and that mantra for the Orthodox is, Lord Jesus Christ, have mercy on me, perhaps a sinner. The Jewish one is, Lord God, have mercy on me. Hindus are chanting, Buddhists chanting, Muslims chanting, right? And the essence here is that this is not requesting prayer, which I've always had a difficulty with. So it's clearly, it is whatever one's structural belief system, if you pray, if you have a great friend who's sick or a relative who's sick, to pray that they get better is a natural and right thinking approach. If you want a new car and you pray for it, well, that's clearly not right thinking at all. And for me, I am a scientist, I've struggled with requesting prayer, but not repetitive prayer is different. So this comes down to the role of the heart, because if you do chant, you end up in your chest, not in your head, right? And the heart we're all obsessed with the Descartesian view that the brain is controlling everything and nothing's coming up the other way. But you talk to most of the public, they'll talk about feelings in their heart, their gut, their groin, and they know they're for real, right? And of course, there's actually very good evidence that the communication runs both ways. So from the heart, there's neurological, biophysical, biochemical, and energetic electromagnetic field communication. So if you look at heart rate variability, it varies. Now, heart rate variability does go down as you get older, but it's not this, it varies about, right? And this is the vital little picture. So if you are frustrated, angry, you get this jaggedy picture here, right? Whereas if you have got the Mozart moment, the Bach moment, the sunset moment, you're in love, you get the sinusoidal pattern. Now, I have wondered whether that might be some sort of fantasy. I chant, and I also do self-hypnosis. And Sean Hammond, hypnotherapist, also chants and does self-hypnosis. And we had a board meeting, and we were in the Caledonian Club. You know from my accent, I'm Scottish, right? So that's the sort of club I would be in. And we'd had a board meeting, and we're afterwards chatting over a drink. And Sean and I were both agreeing that self-hypnosis and chant did not land you in the same place. And that with chant, you were in your chest. And Tony Yardley-Jones, occupational health physician, came over and said, I don't mean to eavesdrop, guys, but he said, I've got a device called HeartMath, secular chant. And he talked to us about this. So he appeared on the following week at the end of my clinic at 6:30 in the evening, where I definitely started having a 10 hours interfacing with patients with this appearance. But I started chanting, and sure enough, actually 60 seconds later, I was in my chest, and that was the pattern. So it wasn't, in fact, in my head, it was in my heart, right? That sense that you're in there is borne out by the physiology. And I put this in because this is all about movement from brain into heart, and the fact that you've got the thalamus synchronizing cortical activity, amygdala, medulla, blood pressure, autonomic nervous system stuff. And of course, you chant, you facilitate appropriate cortical function, which gets you this pattern. And then you start pumping out hormones that make you feel good as well. So above, this is a quote from Maggie Keswick-Jenks, above all, what matters is not to lose the joy of living for the fear of dying. And that is really what the essence of all that we've talked about so far is about. We're not going to be much longer, just a little bit longer, because we're going to move now to walking. So I'm sure most of this audience walk. I don't know if you do long distance walking. I don't know if you've got a pedometer. If you want to protect your bone mineral density, 10,000 steps 3 times a week is a minimum. Pedometers are good for helping you to build your walking. Walking poles, if you're in the country, excellent, so you're less likely to fall over because you become four-legged rather than two-legged. And of course, the right gear, decent boots, correct gear. If you're walking in the west of Scotland, some all-weather gear, quite handy. If you're walking in Palestine, better to have plenty of water in your backpack, particularly if it's May, as I discovered to my cost. So there's a book, The Way of a Pilgrim. Now, it's a Russian book, unknown authorship, possibly Tolstoy, originally published 1881. There's a very nice publication version of it by Darton, Longman and Todd, who it was a privilege, it's some pride that they published my own book. You can see I've put it here. I purchased it on the 18th of January in the morning and I'd finished it by 11 p.m. that night. And I've then gone on to read it multiple times and sent it to various friends over time. And that book firstly made me want to go to Mount Athos because it was all about repetitive chant. And of course, hesychasm is centered on Mount Athos. And here's a picture of Mount Athos. And this is a 6,000-foot peak up here. And we've got St. Paul's Monastery here, the Russian monastery, St. Panteleimon. And I mean, these days there are, at its peak, there were 25,000 monks on Mount Athos. John Julius Norwich, about 40 years ago, the late John Julius Norwich predicted Mount Athos's demise, but in fact it's gone the other way. There are now thousands of new monks there, many who are professional people. And it's a fascinating place to walk around. I'm afraid that it's an all-male only place, which there's reasons for that. It's important to say that there are equivalent areas nearby. This is in northern Greece, Halkidiki, and there are equivalent female areas nearby. And this is certainly one place within a Christian setting that one can see what goes on with repetitive chant. And of course, it was one of the, well, we're looking forward to that trip next year to Nepal and Bhutan to see alternative versions. And then this takes us to the Dome of the Rock, right? Now, this is Jerusalem. This is a picture which we took from the top of the Mount of Olives, Kidron Valley, Garden of Gethsemane down here. Now, Jerusalem, I'm going to talk very briefly about the Celtic concept of the thin place, which is where one feels closer to one's God if one has one. This, of course, is a remarkable place because here is the Abrahamic Rock and the Dome of the Rock, incredibly important place for Muslims. Just over the crest of beyond those trees is the Western Wall, which is the holiest place for Jews, and the Church of the Holy Sepulchre, which is where is the cathedral built over the site of Christ's crucifixion, is literally, I hate this thing, where's that arrow going? Is literally just down here. So it's all within about 400 yards of each other. And of course, that's why there's been a lot of trouble in Jerusalem over the years, isn't it? So in that book, The Journey, we also traveled to Assisi and we did the walk from Spoleto over Monte Sabasio and then down to the Hermitage of St. Francis, which to me gave the essence of St. Francis, I have to say. Remarkable place with St. Francis tiny cell with no window open and stone pillow. And then you go down to Assisi, which is definitely kind of, it's a bit razzmatazz. I don't think it's actually it's not Holy St. Francis, although of course his tomb is there. And I've had the great privilege to walk with the Reverend Dr. Andrew Wakeham Dawson, who is not only a priest, but in fact has got 2 butterflies named after him, was curator of insects at the Natural History Museum, and is editor-in-chief of the World Journal of Entomology. And Andrew has a great advantage that if you hear a bird trill, he can tell you what it is. And if you're looking at flowers, he can name them. And we had walked from the other side of those mountains, and I didn't know, this is Monte Sabasio, which is quite a decent sized mountain. It's 5,000 feet high. But as you go up every 1,000 feet, you see topography, which changes by 1 degree of latitude. So in fact, once we got up here, it actually became quite like the west of Scotland, dare I say it, in the mountains. Down into Assisi, there is St. Francis. And of course, there's a lot of resonance between Christianity and Buddhism. And that picture sums it all up, because St. Francis undoubtedly looking like the Buddha. And we're going to finish just a little in a minute or two. Thin places is a Celtic concept. And this is that sense of something other when one arrives at a geographical place. Not often a city, although you get it, to my mind, in Jerusalem, more often in wild country areas. And Iona, Butte, Patmos, just a couple of photos to show you. There's Patmos, which is the island of, it's close to Turkey. It's where St. John wrote the book of Revelation, and that is the monastery of St. John the Divine. Over here, there's a bar called Jimmy's Bar. And I have to say, I sat in Jimmy's Bar. That's the view from Jimmy's Bar. And I'm not very good at relaxing, truth to tell. I'm not doing anything. I managed, it's the first place I ever sat a few years ago and actually did nothing except take it in. Didn't open a book, an iPhone or anything. This place is absolutely amazing. And it's full of people writing, ironically. And I personally have now written 4 books on Patmos, which has been a great privilege indeed, with lovely walks to break up the day. There is the Cave of the Apocalypse entrance, which is where St. John had his revelation and dictated it to Prochorus, who was his scribe. And that just shows you, that's again another view there, and then looking up the mountain. And if I sound obsessed with Jimmy's Bar, it's there actually. Good bar. And we have to apologise. It says in this blurb that went out, this is Butte, it's not Butte, it's Iona, okay? This is the Abbey.
It didn't look quite like the Abbey.
Oh, yes, this is the Abbey. And it's, this is the Anglican Retreat Centre here. There's the Argyle Hotel, an excellent hostelry around the corner here with a fine chef, which makes for pilgrimage lux. And of course, this was the Reverend MacLeod, who got this all going in the 20s with the Depression. And we all hear John Bell these days on the radio. There's Butte, South End. And this is an area special significance. This is Arran. It's the Holy Isle. The Buddhists are now on the Holy Isle. Just round the corner here is the Little Cymru. The Maharishis are there. And the Christian Retreat Centre of the Western Isles is on the Big Cymru. And there's quite a lot of retreat type stuff kicking off in Butte, which has some special energies. I would like to make some acknowledgements just before I finish. Reverend Gary Bradley, Andrew Wakeham Dawson, I've talked about. Charing Cross Patients Association, we've talked about. Regina Kelman runs my practice and has organised many of these trips. My sister Alison proofread books. Katrina looked after my kids. Yardley Jones for HeartMath. Sean Hammond, hypnotherapist. Feroz Dada and I are working on many of these ideas. And the Baroness Caroline Cox, who's been a huge supporter of Womb Transplant UK and also these ideas. So, thoughts at the end. This stuff is for all, religious and not so inclined. Seek the hidden doors. Chant is open to all, but choose the right route. Whatever route you choose, best if you do have an advisor. Get walking if you can and visit some thin places. And I'll tell you something, if you do long distance walking, chant, and in thin places, you will find, to my mind, great joy. That's my last slide. That is Aaron from Butte, and thank you for your attention.